Where Fred usurped my time and told me to talk about something specific, so I'll try to make a mixture of both.
Okay, wait, that was more confusing.
My name is Ashish Patel. I work with Fred Father.
Are you in this book?
Yes.
Yes, I am in the book. I think my self-description is industrial engineer, process engineer, network security engineer. That's last 15 years of my professional career. So trained as an industrial engineer, graduated from Cornell in 2001, and I've been doing process engineering work since then for a variety of different industries. So healthcare, banking, finance, real estate, and industrial like DuPont. I have experience working in refineries as well. So when I met Don told me that I had the outside perspective that was really necessary to do process analysis in the healthcare system, so I've been nose down doing that kind of work for the last 6 months with Fred. Don also supported a project with Fred. It's an open data project called .graph.org. You guys would, those of you with the internet who browse around to it. Using that data set, which is a referral data set that we FOIA'd from CMS, we're able to see the referral patterns for all Medicare billing professionals across the country. From that data set, we're able to graph it, make a pretty picture, which Fred should walk around and show everyone. And it reflects in a per market basis all the referral relationships for Medicare professionals. And now I'll tell you why this is important. When we're trying to set up ACOs, and ACOs are built up of a bunch of professional physicians that have built-in relationships. Oftentimes they need to be clinically integrated to have the coordinated care outcome that you're seeking. Well, if you're creating a new ACO and you're doing it by going through one by one, and you're saying, Michael, who are your best referral partners? I have to stay back here. So you start with a group of a subset of physicians, and you will ask them for who they'd like to partner with, and then go on and on iteratively until you believe you've built the best team. But you may not have the lowest cost ACO to create using that method. If you reflect on data that we've collected for the last 5 years, you can see where the referral patterns actually exist over the last few years. And you can use that to cast the net over these relationships. Did everybody get to see that? Fred, did you make it all the way around? Okay. Yeah. So the idea is that you cast the net over the very deep Medicare referral relationships that already exist in the market. And you're able to build an ACO from the beginning with relationships that are already very deep and likely to already be clinically integrated. So the startup cost of an ACO, one of the major ones in order to get coordinated care, is to have all your specialists coordinated with maybe one EHR system, one EMR, one backbone for technology to record everything back into, so you can have that, leverage that to coordinate care. If you're looking at historical referral patterns, and often the best relationships already have a method for transitioning data or healthcare records from one primary care to a specialist and back and forth. So that's, in a nutshell, is a description of Patch. It's my time. I still have 6 minutes. So I think I'd like to spend a little bit of time talking about data liquidity, because this is something that I've been exposed to in multiple markets. You'll have very, very diversified enterprise companies, no matter what the industry it's in. It'll have a business unit here that has a database, and a business unit here that has a database, and a business unit here that has a database, and you cannot really do queries across multiple databases. And this I'm seeing over and over in all the hospitals Don and Fred have introduced me to. It's indicative of the healthcare industry as a whole, that they have highly siloed data. And when you're attempting to coordinate care and look at specific category of occurrence, then you need to have laboratory data and time-specific laboratory data and time-specific or incident-specific ER data and ambulatory data and all of these things to really get an understanding of that patient as we're moving through all of these data silos. So one of the projects that we're working on right now is to implement some open source technologies that can sit on top of all the different varied data silos. I think SMART is the name of the tech. One of the less popular, but it's probably going to grow because it's an open tool chain. But you can start bubbling up data out of all the various silos, so you can have this one nice, highly liquid database that you can query against. And that's where I think, as industrial engineers or statisticians attempting to assist in this industry, we're going to be able to help write those queries that understand patients as they transition, or do predictive inferences, because that's what statisticians like to do. Right? We like to make inferences based on data. When we're limited to a single data set, our inferences are only as confident as the number of samples that we're pulling from. So if that patient has records in this data set, this one, and this one, and this one, the best inference we can make of that patient is by correlating all the data across multiple data sets. And that requires data liquidity. And that requires some interoperability for the systems that you already have in your own data warehouse. So the two things that I'd like to really kind of drive home is to start an ACO, you need the lowest possible cost to ensure the success of that. To use this type of referral data to ensure the lowest cost, this is a tool. Then to really get longitudinal study of your patients as they're traversing the healthcare system that you've built, you need data liquidity across all those data silos. And there's a lot of programmers here that are engineers that are incredibly gifted, and they'll be able to deliver these kinds of outcomes for you once you create a system that permits them to do that research. I use probably half or 2/3 of my time, but thank you very much. If you have any questions.